Yes, we will perform a case of this left limb bifurcation lesion. And my sister is Dr. Li Xiaobo from 91st Hospital and Liu Shuiyuan from 91st Hospital. So, Dr. Li Xiaobo, would you please introduce the introduction of the patient?
He is a 75-year-old male, chest for 9 months and aggravated for 1 month. His risk factors of coronary heart disease is hypertension, diameter, and current smoking. He have a normal renal function. BNP is 381. ECG showed pathological Q wave in inferior wall leads, depressed SD segment and involved T wave in anterior wall leads. UCG showed abnormal inferior wall motion, and left ventricle ejection fraction is 53%. Clinical diagnosis is unstable angina and older inferior myocardial infarction, hypertension, and diameter. This is ECG. From baseline CEG of RCA, we can see the stent implanted last year in proximal RCA is okay. Next. This is baseline CEG of our left coronary artery. From code view, we can see distal left main and the proximal LED circle is a true bifurcation, and the median type is 111. Distal segment and the proximal segment of a circle have severe stenosis. Proximal LED is very severe stenosis, and the lesion is severe calcified. From RAO cranial view, the distal LED and the middle LED is okay. Proximal LED and the diagonal one is a true bifurcation, and the lesion of a diagonal is very diffuse. Next. This is the AP cranial. From spider view, the distal left main true bifurcation is showed very clearly. Next. Before PCI, we calculate the risk stratification routinely. Syntax score is 28, and the syntax 2 for PCI, 4 years mortality is 5.1%. For cabbage is 10.9%. According to the definition criteria of Professor Chen, the distal left main bifurcation is a complex bifurcation. Next. Before PCI, we check the QFR of LED and the circ. QFR of circ is 0.63. LED is 0.58. Next. Okay, for this lesion, our stent strategy is the PCI will be performed by support of IBP. For the distal left main bifurcation, we will use DK crush stent technique, and the IVUS will be used to guide this PCI. If necessary, shockwave will be used for the calcified lesion of proximal LED.
So for this particular case, just as you mentioned and Dr. Lee introduced, it's a typical complex bifurcation lesions. Circumflex lesion length is longer than 10 millimeter, and with in terms of main vessel LED to left main is a long lesion with severe calcifications from these AP caudal views. So I think according to the definition criteria, I think according to the definition 2 trial, 1 year and 3 year result for this kind of complex lesions, 2 stent technique, especially with the DK crush, where resulting favor long-term follow-up. So for this case, Doctor, will you use intracorneal imaging guidance? And if you use, you will choose IVUS for OCT for this particular case.
Yes, very, very good question. And for this case, especially for the with myocardial infarction of inferior wall, and we also use IBP support for the whole procedure. For this case with left main bifurcation lesion, I think IVUS is the best choice for this case. From today's angio, we find the severe stenosis at the osteo to proximal LED. We also find the severe stenosis at the osteo circumflex. For this kind of situation, we use small balloon to old balloon to pre-dilate the LED. We want to stop stop the anterior flow of the LED when we use IVUS checking. and we use a 2O balloon to pre-dilate next. After wiring circumflex, yes, LAD and first diagonal. We also find a very interesting situation for this small diagonal. Even though it's small, but it's very important for this case, just because the patient with old myocardial infarction of the inferior wall. So LAD and the diagonal is very important for this case. If we lose, the diagonal maybe will influence the whole left ventricular function in the future. So we use 3 wire, one in the LAD, one in the circumflex, and another in the diagonal. Oh, yes, we can see. Just we can see it can negotiate in the LAD very smoothly with a run-through wire. This is a run-through wire with one curve. So it's enough. If we still failed, okay, change the view to the RL cranial or AP quarter, we can find the osteo LAD clearly. So after pre-dilate with a 2O balloon, we check the IVUS. So next, so after that, we check the LAD IVUS.
Let me show the IVUS imaging. The first run, we check IVUS from the distal LAD to left main. Here, this point is the distal LAD. We can see the vessel is normal. The vessel diameter about 3.8. Then go and pull back about 7 millimeter. We can see a big septal will join LAD. So this point is the distal landing zone is over the distal septal about 7 millimeter. Then go and pull back, we can see calcification. Then go and pull back here, and the distal LAD vessel diameter about 3.4 millimeter. Then go and pull back, we can see the calcification angle is not more than 180%. Then go and pull back here, we can see the diagonal, we are joining LAD. Here, this is the proximal LAD. The proximal LAD vessel diameter about 4 millimeter, and this point is a minimal lumen area. The area is just 1.6 millimeter square, and the plaque burden is about 85%. And here, the calcification angle is about 270 degrees. But after pre-dilation, we can see a crack. Then go pull back. This is the proximal LAD. And then here, we can see circumflex will join LAD. Then go and pull back. This is a POC, and this is the distal left main. The distal left main area is just 5.1 millimeter square, and the plaque burden is more than 75%. Then go and pull back. This is the body left main, and the body left main vessel diameter about 5 millimeter square. 5 millimeter. Then go and pull back. This is the ostium left main. We measure the narrowness from the distal landing zone to ostium left main is about 42 millimeter. And the distal landing zone, from the distal landing zone to the first diagonal, the narrowness is about 21 millimeter. From the distal landing zone to ostium LAD, the narrowness is 31 millimeter. Okay, this is the LAD run.
Test. Okay.
Very
Okay. Ready? Enough.
What do you see?
Dissection.
Yeah.
So we can.
But I think the ostimal diagonal looks okay.
Okay. Yes,
Yeah.
I think.
Yeah.
Okay, we can standing.
We can stand in it.
Yes.
Yeah.
Okay, standing. Give me.
So for the first stand, I think maybe 3.5, 20, 29.
29. Yes.
Okay.
Enough.
So considering the total lesion length from the left main to the middle LAD landing zone is 42. So maybe we need 2 stand.
Yes.
The first stand will put from the middle LAD to the proximal LAD will fully cover the ostimal diagonal.
Yeah.
Of course, we're also avoiding overlapping segment at the ostimal diagonal. Yeah.
Yes.
So from this view, I think lesion prepare is very important for this severe calcification.
Yes.
So we will do the NC balloon predilation again. If we still cannot advance the stent, Doctor, will you change your strategy? Will you use a low ablation or a laser therapy
So
for
we
this
can
case?
use yes, we can use double channel caster to make the body wire technique.
Okay.
So this is a 3O NC balloon pre-dilate
14,
14, 16.
16.
Okay, done. We can see the
Yeah.
3O NC balloon pre-dilate very well.
Okay.
We cannot see.
Here, yeah.
Okay, go up.
There is a severe
14,
calcification.
16.
16.
Okay, done. I think it's okay.
Okay.
Go up. 14, 16. Okay, done. Okay, give me another wire.
Oh,
Maybe double channel caster. Prepare for me.
So next step, doctor will use dual lumen cassette to advance second wire
So
to the distal LED. So body wire will give more support
yes, we
compared
use
with
body
the
wire.
single wire. Yeah, because you can see from the angiogram actually
Okay.
the stack of the stent advancing into the mid LED is angulated with the calcification.
Yes.
Yeah.
I think there is a big angulation here,
Maybe
even though we cannot find that from the angel.
So because after balloon predilation, there is a dissection. So
Yes.
maybe body wire is safer. Yeah. You see a very good skill. Yeah. Yeah, you successfully avoid the LED.
Still failed.
Yeah.
Okay.
Nice. You nearly successful. Okay, good.
I'll pull back the
Angulated.
yes,
Okay, nice.
jet wire.
Yeah.
Okay.
So after body wire, doctor successfully advanced the stent
test
to the middle LED.
Okay, just okay. Okay, give me AP spider view. So first the stand will cross over the side range Austin.
Yeah, the fully cover the first diagonal. Yeah.
Okay, test.
Just at the.
Okay, put it back.
Pull back a little. Yeah.
Okay, test. Okay, give me a IO cranial.
To check the distal position.
Yes, the distal landing zoom is it's also very important for this case. Yeah. See it?
Yeah, it's good. I think it's good.
Yeah.
So the 3.529 stem fully cover from the middle AD to the optimal AD. Yeah. Looks expansion is good from at least from the angel.
Okay, done.
Considering the ostimal circumflex is a very eccentric fibric plug burdens, I think before you put a stent, we can still use the NC balloon to do the lesion prepare.
Yes. Yeah.
Already.
No, circumflex.
So it's a typical high-risk PCIs, or the inferior MI with the distal left main. So with the IVP support, so when we treated this high-risk patient, circulated support can give us quite a long time to treat this challenger case. So first, we will treat this distal left main with a DK crush. Then we will do the angio again to evaluate the diagonal and make a decision to rescue the first diagonal. Yeah.
Okay, done. So for this very complex bifurcation with very sharp angulation at the osteo, circumflex and osteo side branch, so down, it's very important to use IVUS protection, IBP protection before procedure.
Yeah.
So, yes, we think IBP is very, very necessary for this kind of issue. Go up to 14.
14.
Okay, done. Still on the expansion, we use higher pressure to pre-dilate the osteo circumflex. Okay, done. Up. 14, 16. Okay, done. This is a 3O NC balloon pre-dilate the circumflex lesion. After that, we can check. Okay.
Okay.
Give me test. If there is no dissection and the flow is okay, okay,
Okay.
we can standing.
So after side branch standing and the side branch optimization, we will do the angiogram
Yes.
to check there is no distal edges dissection. Then we will do the
Okay.
balloon crush.
Okay. Okay. We can see the stand for expansion.
Okay, good.
Okay. No dissection of the distal of the stand segment. 那个 H.
Go to AP caudal.
Okay, epicorder.
Looks good.
Okay.
Okay.
Okay. We perform the first crush with a 4-0 balloon.
Okay.
Spider view.
Good. Nice.
12,
Nice.
14, 16.
Good.
Okay.
Okay.
Down.
Nice.
It's better.
Yeah. Fully crush.
Yes. So we
So
can.
we already check the IVUS after balloon crush to
Sure.
see it's a fully
Okay,
crush.
give me
It's
IVUS.
very important.
Okay, I will pull back the proximal LED.
Yes.
LED. Yeah.
Is a POC, and we can see two stand.
Yes.
Two
This is
stand
still
here.
LED.
The crush
Yeah.
is good.
Okay. For back.
This is the first key point of decay crush.
Yes.
First revive we should from the proximal cell, avoiding distal access. Because for the wider this angle bifurcation, if we from the distal cell, maybe the wire will go on beyond under the stand structure. So that's why we use the first jet wire as a marker and use the third wire to rewind the circumflex.
3-0 NC balloon.
So still you use a 4-0 balloon for LED
Yes.
and the 3-0 balloon for circumflex
Yes.
to perform first casing. Yeah.
Yes. So this is a 3-0 NC balloon to push
Yeah.
into the circumflex. If we find the revive position is good, okay, we can find the ballooning crossover to the circumflex. It was easier.
I think that will be easier.
No. Okay.
Yes.
Nice.
Okay. Graph.
12,
12, 14,
14,
16.
16.
Okay, done. Okay.
Before first casing, you will use the NC balloon sequentially post-dilate circumflex
Yeah.
and the LED. Yeah.
Yes. Circumflex first. 14, 16, 18. 18. Okay. Done. Okay. LED. 14,
12,
16. 14. Okay, done. Later.
I see.
Overlap.
Definitely overlap already.
Oh, we can see the angulation.
Yeah, yeah.
How about the austere?
Not sure. I think still we need a cranial view
Epicranial.
to check the stand is fully covered the optimal left main. Yeah.
Yeah. Okay.
We use a floppy wire as a mark. What do you think?
I think a little back is better.
Yeah, I think so. Because for the distal part, I think it's long enough.
Yes.
We have fully overlap, at least 3
Test.
millimeter.
Okay. Sniff. Okay. Still a little back. I think it's better.
Yeah. Maybe 1 millimeter.
Just test. Okay. Okay. No. Okay. Sniff. Okay.
I think here we have definitely fully covered.
Yes. I need to push a little back. Yes. Test for a while. Yes.
I think now.
RO cranial. Okay. Show the distal part of the
cranial.
IO quarter. We don't need the
Only
contrast.
cine, yeah.
Yes.
Okay.
I think it's a fully
Yes.
overlap.
Up.
Up.
12.
Yeah. Okay, done.
Good.
Yes.
Good Stent expansion.
Yes, I think stent was full expansion. Okay.